Next, we're going to hear from your neighbor in the north, from Maine Care, and Michelle Probert, who is the Director of Strategic Initiatives with Maine Care. Michelle joined the department in February of 2011, and not only oversees the department's value-based purchasing strategies, but also oversees its effort to restructure Maine Care's non-emergency transportation system. Prior to joining Maine Care, Michelle actually worked here in the state of Massachusetts. She worked in the Executive Office of Health and Human Services and led some cross-secretariat teams around defining services and reform reimbursement for $700 million in contracting for human services. So she transitioned from Massachusetts over to Maine recently, and we're going to hear about some of the efforts that Maine has underway to reform its integrated care delivery system. Michelle?
Thanks, Tricia. It's a pleasure to be back in Boston and nice to see some familiar faces in the audience. And I have to thank everyone in the room for doing such stellar work in healthcare, that your reputation really goes a long way. And it goes a long way for me personally, because I learned not too far into trying to establish myself in the healthcare community in Maine, that rather than delving into the details of what I had done in the past and how that was applicable to what we were trying to do in Maine, all I really needed to say was, I used to work for the state of Massachusetts. And people would get kind of starry-eyed and say, oh. And that doesn't just happen in Maine. It happens when I travel to other states throughout the country. So thank you. I don't even need to say I didn't work for Mass Health. So I took the instruction to be brief very seriously, and so I have a very high-level presentation for you today about the work that we are doing around value-based purchasing in the state of Maine. I do welcome you to check out our website, which is up on the screen. OMS is for Office of Maine Care Services, and VBP is for value-based purchasing, just so that URL makes a little bit more sense. But feel free to read more there, and feel free to find me afterwards. I'd be happy to talk at length. To give you a little bit of a context for the state of Maine and what the Medicaid program looks like there and some of the struggles that we face, approximately 1 in 4 Mainers are currently enrolled in Maine Care, and Maine Care accounts for about 1/3 of Maine's overall budget. We are wholly a fee-for-service state. We do not have managed care. Almost all of our primary care providers are currently participating in our primary care case management, or PCCM, program. That program does not serve everybody. It excludes dual eligibles, as well as children with special health care needs and our members who receive home and community-based waiver services. We are rated the 8th healthiest state in the nation. We also have the oldest median age in the nation, and that age is going up. I also want to state that there is a really strong foundation amongst providers in this state for healthcare reform. We, for a small state of about 1.2-ish million, I think we have 1 pioneer ACO, and we also have 3 shared savings ACOs under the Medicare program. And there's also a strong collaboration on the commercial side across payers, and a lot of activity developing commercial ACOs, as well as what we're doing for Maine Care. So in August 2011, getting close to 1.5 years ago, Maine Care announced our value-based purchasing strategy. The state, per directive of the legislature, had originally been looking into introducing managed care to the state. With a new administration, that plan was revisited, and we really went in the direction of taking advantage of the grassroots efforts that are happening rather than bringing in a third-party entity. I should probably change this slide, because I will say that with a new legislature and with continued economic pressures, there is the managed care drum may start beating again. But regardless of the future for managed care in this state, the department and the state as a whole remains very committed to changing the delivery system as well. And our value-based purchasing has 3 main components. At the bottom is strengthening primary care. It's at the bottom not because it's least important, but it's because it's the foundation for everything that we're working on. And in this presentation, I'll talk a little bit about our patient-centered medical home pilot and our Maine Care Health Homes initiative. We're also doing some work to reform a current pay-for-performance program that we have for PCPs in the state. And A lot of the work around primary care is focused on improving transitions of care. We also have an initiative where our Office of Main Care Services works directly with all of the hospitals and surrounding PCPs across the whole state to target the highest utilizers of the emergency department and try to get them back connected into the primary care system with care management resources. And that's been a successful, completely unfunded effort. Over the past year, we estimate that we saved about $5 to $6 million over the previous year. And then at the top, our umbrella strategy, which is more about structural reform, but again, rooted in the foundation of transforming primary care, is what we're calling our Accountable Communities Initiative, which is a shared savings Medicaid ACO model. So this is a very busy slide, but I like it because I think it does a pretty good job of illustrating the complexity of the patients that we serve, and also what needs to happen beyond the medical system, beyond behavioral and physical health integration, to looking at the larger psychosocial picture, everything from transportation to do you have adequate heat in the winter. So this slide shows that the model that Maine has instituted for our patient-centered medical home pilot and for the Help Homes initiative going forward. And we define a medical home as being the combination of a PCP practice as well as a community care team for a high-needs individual. And for all patients, the point of access of care is that PCMH practice. For the highest need individuals, we estimate about the top 5% of the population, a community care team provides wraparound supports to the practice as to coordinate care, provide intensive care management, and also connect to the larger community-based organizations and resources to help support that individual. So this is really the basis for the model that we're working on in Maine, and I will say that we've gained a lot of inspiration from models in North Carolina with their community care networks, as well as in Vermont with their Blueprint for Care. So in the state right now, we have about 540 primary care practice sites specifically. Over 400 of those are accept Maine Care, and about all of those providers are primary care case management providers. So that's the whole picture. We started out 2 years ago with a multi-payer patient-centered medical home pilot of 25 sites. About a year ago, Medicare joined that pilot. So we had Medicaid, Medicare, Anthem, Harvard Pilgrim, and Aetna, which is close to all of the payers that we have in Maine, which probably seems like a small number to everyone here. But so we started off with the 25 practices. With Medicare on board, we are expanding this January to include 50 more practices that are in the multi-payer pilot. And then we've been doing a lot of work over the past year to implement the Help Homes initiative in Maine, part of the Affordable Care Act. And with the enhanced 90-10 match of the Help Homes initiative, Maine Care is able to spend the same that we are now on things like PCCM and our PCMH practices and the community care teams. And we're going from 25 practices to what we're hoping is going to be close to 125, 130 practices, which would be about a third of the practices in the state, which we think is getting close to being a tipping point and very exciting. The ability to put those resources out into the community, especially in economic times like this, is an opportunity that we could not pass up. And I will say that all of the practices that are going to be engaged in the Help Homes initiative will be NCQA certified. All of the practices in the multi-payer pilot will be certified by this January 1 at the latest. For practices that are part of Help Homes outside of the multi-payer pilot, they need to attain NCQA certification by June 30th of the coming year. So those are my slides that kind of give the context of the primary care foundation in the state. And then we have our Accountable Communities initiative, which again is built on the foundation of primary care. And At the surface, it's pretty simple. We're basically allowing providers to come together to engage in an alternative contract with the state, and if that group of providers, which has to include a primary care provider, but other than that, we're leaving it pretty open in terms of who can be a part of the accountable community. If they are able to achieve savings on an assigned population and maintain or achieve quality benchmarks, then they can share in a portion of those savings. This is going to be for all Medicaid members in the state, and so nobody is going to be excluded from benefiting from the accountable communities. All behavioral health costs will be included. Long-term care, we are putting in our optional column, and so if there are some innovative partnerships between, for example, nursing facilities and hospitals, et cetera, then we welcome and encourage those partnerships to form, and the long-term care costs could be included in the model as well, but we are not mandating it quite yet because we don't think that we're there and have some further work to do. I will say, while we're being pretty open about who can be part of an accountable community, we have been very clear that in order to be an accountable community, you need to show that you are collaborating with community-based organizations. You need to commit to interest in the accountable community. Then you need to show that you have very strong relationships with the larger community as well. I also want to state that a couple things we found very important. One is that we have based this model starting with the Medicare shared savings model, in part because we know from the provider perspective, it's very frustrating to have to redesign yourself as a different kind of accountable care organization depending on who the payer is. And so where it makes sense, we've tried to go for alignment as much as possible, realizing also that the Medicaid population is different. And so we go a little bit further in terms of requiring the behavioral health integration and leadership of patients and families in quality improvement efforts, as well as in self-management of their own care. And lastly, I think we've tried to remain high level enough so that we're encouraging innovation. We do believe that primary care is the foundation, that care management, especially for high needs members, is really crucial. However, we're not pretending that at the state we have come up with the best way to achieve savings and improve care for the population. And so we don't want to say this is exactly how you should deliver services to all of your main care members, because 2 years from now, I'm sure there's going to be the next greatest thing and how we're really going to achieve what we're trying to do this time. So we are trying to be clear about what outcomes we're trying to achieve, but stay out of the weeds. Let providers get into the weeds. That's what they're best at doing. The state should not be in the weeds. So the model, we have two different models, and we had a lot of conversations over the course of the year with behavioral health providers, as well as with our large health systems and our provider community at large. And we realized that we need to make it easy to participate, partly because we are very interested in smaller organizations participating in accountable communities, and they do not have capacity to take on much, if any, risk at this point. Also, even with our large health systems in the state, I think our Commissioner of Health and Human Services likes to say that we're operating with a slight deficit in trust at the moment due to implementation of a new claim system a couple of years ago. We are literally in debt to a number of our health systems and hospitals and still paying them back. And when you put that debt on top of the more than adequate rates that Medicaid always pays for its services, then we have received strong feedback that a lot of providers in the state already consider themselves at risk by accepting main care, period, without layering additional risk onto that. So having said that, our first model, we are looking for a minimum of 1,000 patients to be attributed, which we don't think is a lot of patients, so we can keep it small. Those accountable communities could share in a maximum of 50% of savings, and they're not accountable for any downside risk in the first 3 years of the model. So we like to think that there's no harm in trying here. I know that it's a lot of work to institute the kind of change that's necessary to achieve lower costs and improved health outcomes, but in this case, if you fail, then it's on the state. Our second model, we need a minimum of 2,000 patients attributed. In exchange for taking on some risk in the second model, you can share up to 60% of savings based on your quality performance. There's still no downside risk in the first year and the second year, and this mirrors the Medicare shared savings model. You'd be accountable for up to 5% of losses, and in the third year, up to 10%. So this is my little analogy when there's so much going on in healthcare reform right now and so many different phrases getting thrown around that it gets pretty confusing. And so a lot of providers and consumers in our state have said, I don't get it. What's a health home? What's an accountable community? How are they different? How are they the same? And so I've chosen to start describing it as when you think about an accountable community or an ACO model in general, it's really a vehicle. It's a way to try to change incentives away from volume-based towards value-based purchasing. However, you can have a great vehicle, you can have a great bicycle, top of the line, really shiny and new and amazing, and if it's sitting in your garage and you don't use it or you're not really in shape, you're not going to get anywhere fast. So we can institute accountable communities, and it's not going to get us anywhere without having people, or in this case providers, who actually are committed to staying in shape and riding that bicycle and reforming the delivery of care on the ground. So our patient-centered medical home model and our health homes initiative, it's an on-the-ground model to provide more coordinated care, to really target those high-needs individuals. And while we're not mandating anything, we think that our future PCMH and health homes are going to make excellent riders for our accountable community bicycles. And that is all I have. Thank you very much, and I'll pass it on.